let's come to the gestational trophoblastic neoplasia. So these are all the other molar pregnancy except the herediform mole, or you can say the complete partial mole. So other condition like invasive moles are the malignancy choriocarcinoma. So they are under the category of the gestational trophoblast neoplasia. Okay. And these are malignant persistent tumor derived from the trophoblast of placenta. So what is the important feature? They are the undifferentiated novuli because they are the malignant condition. Undifferentiated novuli. Okay, and the number one is the invasive mole. Okay, you know better. It's invading the myometrium, and it's mostly follow the complete mole, and then it's the arch of the partial mole. So the molar pregnancy is also followed by the invasive. So you can check the beta HCG. Okay, so if it's a palato, so one of it's could be the invasive mole. Okay, then and in the choriocarcinoma, okay, which usually follow any form of pregnancy, but mostly the complete mole pregnancy. Any pregnancy means it's follow the normal pregnancy or the ectopic pregnancy. Okay, any pregnancy event. So it can follow by the choriocarcinoma. Okay, and the placental side trophoblastic tumor, very rare tumor. Okay, so it's on the bed of the placenta. Okay, so in the invasive locally malignant, it's not invading the other organ or only limited to the pelvis or the myometrium. Okay, and in the microscope you see the complete mole. Okay, and there is no fetus in this condition. Only fetus is present in the partial mole. Okay, and invasion of the myometrium and the blood vessel. So and the hydropic villi which are present here, so they may run into the blood and may embolize the distant organ. They are not metastatizing the distant organ, but they can embolize the distant organ. Okay, so no metastasis in the distant organ in the invasive mole, but there is embolization. Okay, and they reaches, but they do not grow in the distant organ. And then the differential diagnosis, of course, you look the plateau beta HCG after molar evacuation. Okay, and they are confirmed by the ultrasound where you see the undifferentiated uterine mass plus myometrium invasion. Okay, in the treatment, they are sensitive to single agent chemotherapy. The 100% cure chances, but you can repeat the hereditary form mole treatment, dilation and curative, then follow the single agent chemotherapy. So treatment chances are 100%. So initially it's difficult, but this is thanks to methotrexate, single agent chemotherapy. So cure rate are 100%. Okay, in the choriocarcinoma, the malignant tumor, which is invading the distant organ, lung, liver, bone, brain. So the invasion define the risk of the tumor. Okay, so if it's involving the brain and liver, so it's a high risk choriocarcinoma. If it's limited to the lung, so it's a low risk. So invasion increase the risk of the choriocarcinoma condition. Okay, here you see in the choriocarcinoma, cytotrophoblast and syncytiotrophoblasts both are involved. You know what trophoblast has two parts. One is a syncytiotrophoblasts, other is a cytotrophoblast. Okay, so choriocarcinoma involve both, while the placental side is only involved the cytotrophoblast. In the diagnosis, the beta HCG, of course, Plato beta HCG after molar pregnancy. Okay, and you can confirm by the ultrasound where you see the other features. Okay, invasion, and you can look for the chest X-ray for the metastasis and the MRI of the pelvis. Okay, and there more than 90% are the sensitive to the chemotherapy. So depend upon the condition. If it's a low risk, we start with a single agent chemotherapy. If it's a high risk choriocarcinoma, where we give the combined the chemotherapy. Okay, but so curative chances are more than 90%. Well, the placental, it's a extremely rare and slow growing malignant tumor of trophoblast, where you only see the cytotrophoblast proliferation. So because the beta HCG associated with the syncytiotrophoblasts. So if it's only limited to cytotrophoblast, you do not see the high level of beta HCG in this condition. So very differentiated point from the choriocarcinoma and placental side trophoblastic tumor. Okay, you do not see the high level of beta HCG. So in the macro, distinct from the villus trophoblast, you see then infiltrate invade the decidua, myometrium, and the spiral arteries. Okay, but what is the diagnostic? Because there is no high level of beta HCG. Okay, so because there is no sensitio trophoblast proliferation, little or no beta HCG. What is the diagnostic? Diagnostic is the human placental lactogen level is high, so it's high in the placental side trophoblastic tumor, and you can see in the ultrasound uterine mass with the cystic and the solid region. So when you see, it's the placental side trophoblast tumor. Okay, so it's a resistant to chemotherapy, although it's a rare tumor, but it is resistant to chemotherapy. So the option is the surgery mean total abdominal hysterectomy. And usually you see follow the non-molar pregnancy mean the abortion or ectopic pregnancy. So it's follow the choriocarcinoma follow the mostly molar pregnancy while they follow the non-molar pregnancy. Here is the invasive myometrium. Okay, you can see the myometrial invasion and the cyst. You can see the cyst-like structure are present in invasive identiform mole. Okay, so here you can see vesicle. So involvement of the myometrium means it's an invasive mole. Okay. Let's cover the GTN. What is the presentation where you see the persistent vaginal bleeding? Persistent vaginal bleeding with the history of pregnancy event, any pregnancy event, normal pregnancy, molar pregnancy, the ectopic pregnancy, abortion, any event. If she give the history and which is followed by the early vaginal bleeding, so it's one of the symptom for the GTN. Okay. So what are signs? You see the anemia and also see the metastasis. Okay, and in the you see the abdomen. It's a large soft uterus with metastatic signs. Okay, I mean it's a liver. You can see the palpate the liver. Okay, and if you vaginal, you see enlarged uterus with vaginal masses. I mean it's involved the vagina. Okay, and you see the full head index. So these are the signs for the GTN. Okay, we divide into two groups: low risk and the high risk condition. Low risk mean the previous pregnancy is less than 4 months the event, and there is no liver and brain metastasis and no previous chemotherapy. So this is a low risk condition. If there is more than 4 months from pregnancy and liver brain metastasis and the previous history of chemotherapy, so this is the high risk condition. Okay. And the pathology, you see the enlarged febrile tissue and plus the areas of the hemorrhage and necrosis. Hemorrhage and necrosis, when you see, and the febrile tissue enlarged uterus, so this is the sign for the gestational trophoblast neoplasia. Okay, so and in the microscope, of course, you see the undifferentiated novula because it's a malignant. We look at the grading mean when this malignant and undifferentiated cell are less than 5% grade 1, when 5 to 50 grade 2, when more than 50 it's a grade 3 condition. Okay, in investigation, of course, you do the ultrasound and look for the beta ECG. Okay, and check the chest X-ray and the MRI for the complication or the metastasis. Okay, and assess the fitness for the treatment because we are going for the chemotherapy. So check the LFT, liver condition, and the renal function test. Okay. In the metastasis are separate direct into surrounding areas, adenexa or the myometrium like the arteries, vessels, and rarely by the lymphatic, but mostly by the blood, lung, bone, liver, brain. Lung, bone, liver, brain. Liver, brain involvement is the high risk condition. Okay. According to the separate, FIGO has classified. So if it's limited to uterus, it's stage 1. If it's local separate, mean uterus, ovary, and vagina, mean in the pelvis, it's a stage 2. And if it's involved the lungs, so it's a stage 3. If it's involved the other organ, mean the liver, the brain, so it's a stage 4. So depend upon the separate. in the treatment, we divide into low risk and the high risk. In the low risk, we give the single agent, I mean the methotrexate. So these are actually three where you can see the methotrexate, the actinomycin, and the cyclophosphamide. Okay, so these are three drugs actually. So we give single agent and follow up for the 1 year. So after the negative beta ICG. So if the beta ICG comes negative, you should follow for the 1 year. Okay. So and if the condition is the high risk, we go for the EMACO. So these are other drugs. Okay. So where we combine chemo. Okay. So mean you give the not a single drug, so you the combination and follow up for 1 year after the negative beta HCG. And if the condition is complicated or the patient is chemo resistant, you go for the hysterectomy. So although I defined the simplest form of low risk and high risk, but if you look at the FIGO classification of the low risk and high, they have scored them 0 to 6 is the low risk, the more than 7 is the high risk condition. So depend upon the age, the pregnancy event, okay, and the index interval from the index, pregnancy, the pre-treatment, the HCG. Okay, so what is the HCG level and the size of the tumor and the metastasis and the chemotherapy history, failed chemotherapy. So they depend upon this. So we count the total 0, 1, 2, 3, 4. If it's more than 7, it's a high risk. If it's less than 6 or 0 to 6, it's a low risk. How we approach the GTN? So look for the FIGO scoring. If it's less than 6, it's a low risk. Okay, and give the single agent chemotherapy. If it's a high risk, means score is more than 6, we give the combination chemotherapy. Okay, so if it's not working, then you come to the combination therapy. Okay, so and also follow the beta HCG level serial for at least 1 year. Okay, and resolution lifelong HCG follow up. Okay, and if it's relapse resistant disease, then the second line go for the second line chemotherapy and plus or minus the surgical debugging. I mean, you can remove the uterus. Okay. In case of chemotherapy, according to FIGO stage 1, stage 2, 3, stage 4. Okay, so these are different drugs. So a single, you usually see the single agent chemotherapy and the combination chemotherapy, or the other option is the hysterectomy. So what are the single agent and the combined? So single agent which you usually use in the low risk condition. Okay, so these are the methotrexate, folinic acid, and the actinomycin D and the cyclophosphamide. So on the day 1, 3, 5, and 7, you give this dose IM or IV, and day 2, 2, 4, 6, 8 with the folinic acid, and for day 1 to 5, you continue these drugs. Okay, and in this condition, EMACO, which is the etoposide, the actinomycin, methotrexate, okay, and these two, cyclophosphamide and the vincristine, okay, are unkind. So these are actually the EMACO, so which we follow in the high risk condition, okay. On day 1, this dosage, day 2 this, and day 8 this. So 3, 4, 5, 6, no dose. At day 8 you give, and also repeat this cycle on the 15, 6, so 16 and 22. Okay, every 2 weeks. So this is followed. So this is all about the GTD. Thank you very much. Allah Hafiz.